We have made it to the last one. So our last video here about chapter 10 with these drugs used commonly in surgery. All right, so diuretics, and we mentioned this one in the last one. So this is increasing the amount of urine that's excreted. And why would we need to do that? So it helps reduce edema, which is swelling. So again, if somebody's really swollen, diuretics help kind of flush out some of that fluid to help that swelling go down. It can help treat congestive heart failure, which is whenever fluid builds up around the heart. So releasing that extra fluid helps kind of drain that. It also helps treat hypertension, which is why we were talking about it last time. So by decreasing the water there, it can help change the blood volume and help the blood pressure go down. It also helps increase urine production and elimination that can be useful in different, especially kidney diseases. So there are different types that work a little bit differently, but all for the same effect. So they're all increasing that urine output. So some of those types, we have what are called carbonic anhydrase inhibitors. So these inhibit an enzyme, that anhydrase. So inhibition causes more excretion of hydrogen, which is going to cause more excretion of sodium, which then causes more water to go. So as more molecules are released in the urine, water goes with those to help dilute them. So if we're increasing the amount of ions that are going out in the urine, that by default pulls the water out with them. Loop diuretics, so if you remember your anatomy, the loop of Henle that's in the kidneys that allow for that like absorption and reabsorption of ions and molecules in water. So those loop diuretics prevent the reabsorption of sodium and chloride. So that puts more of that in the urine, which again draws water to go with it. And then osmotic diuretics, this is going to play on that hypotonic, hypertonic environment. So it creates a hypertonic environment, so it's pulling the fluid out of the cells by osmosis that then increases that plasma volume to decrease the water reabsorption. So if water is not being reabsorbed, it's going out. All right, so some dyes and stains. Now we're back to kind of our diagnostic or uses of these things. So a couple different uses. So a dye is going to be short-term coloration that's easily removed. So like, especially with the surgical environment, you know, putting a mark around where the incision is going to be, or if there's something in particular that needs to be highlighted, essentially it's drawing on the patient, but then that washes away over time. So gelatin violet and methylene blue are the two most common. Whereas a stain, this is longer or permanent, so this is not used in the surgery. This is more in histology. So if somebody has had a biopsy, stains, you know, we talked about like the Gram stain, we talked about acid-fast stains whenever we were talking about the different prokaryotic cells. So these stains are permanently staining the cells more for diagnostic purposes. Now, in the OR, there are some emergency drugs. So on the emergency drug cart, you're always going to find these. One is to help with malignant hyperthermia, which is a rare genetic disorder, but it's not really, unless somebody's already had a surgery and know that they have that, this is something that is usually, especially first surgeries, would be something that could occur during that because, again, it's a genetic thing. So for that malignant hypothermia, dantrolene is what is used, and it's a muscle relaxer. Now, this is one that I do want you to know. So again, most of the drugs we talk about, I give you some examples just so you know them. Dantrolene, though, is one that you'll need to know. You need to know that that is on the emergency drug cart, and it's used to treat that malignant hyperthermia. Allergic reactions can happen to the different drugs that are being used during surgery. So an antihistamine or corticosteroid would be on that drug cart. Cardiac arrest, so their heart stopping, so we need to stimulate the heart. So adenosine, adrenaline, aspirin, diltiazem, lidocaine, nitroglycerin, these are all examples. And again, this was something that would be on that surgeon preference card. So depending on the surgery and even just the preference of the surgeon, they may want you to have different drugs available, or the anesthesiologist might want to have different drugs available if cardiac arrest would occur. And then the last one is the respiratory distress. So again, if they stop breathing, either from an overdose from those opiates that are being used, or just from other reasons. So neuromuscular blockers, or bronchodilators, corticosteroids, there are others as well. So for most of these, except malignant hyperthermia, there are multiple options. So that's what would be on that surgeon preference card, so you knew which ones were preferred. Dantrolene, though, there's only one for that, and it's for that malignant hyperthermia. Emetics, so these are going to induce vomiting. So either directly by stimulating the gastric reflex, so like syrup, Avipacap or alum. So that's going to directly work at the GI system to induce vomiting, or we can use more of a systemic indirect called apomorphine, and that's going to stimulate the vomiting reflex in the brain. So either triggering the stomach or triggering the system more like in the brain to cause that vomiting. So these are not recommended for strong acids or bases, or we don't use strong acids or bases, petroleum-based, or anything that could potentially be a convulsant for these. Now, kind of staying in the stomach, we have gastric agents. So these are going to have an effect on the stomach. So things like H2 receptor blockers, and this is histamine. And usually when we think about histamine, we're thinking about an allergic reaction, which is true. But those are H1 receptors. H2 receptors, are in the stomach, and they increase acid production. So by blocking them, you're going to decrease secretions and hydrochloric acid. So some examples of these are cimetidine, famotidine, ranitidine, so Zantac, that's a common one that gets used. So again, they're going to be decreasing kind of that heartburn or decreasing those secretions. Now some different hormones that regulate our body functions. So corticosteroids that we mentioned a couple times here already, these are made by the adrenal cortex. So things like glucocorticoids, mineralocorticoids, and our sex hormones like testosterone and estrogen fall under here as well. Some other hormones, insulin and glucagon that are made by the pancreas, those are going to control our blood sugar. So insulin decreases blood sugar levels. So like after we've eaten, glucagon is going to raise it. So if it's been a while since we've eaten, glucagon's like, hey, we need some more blood sugar, and it gets released. Both of them, though, from the pancreas. Then our prostaglandins, these are secreted by lots of different cells, but they have a nearby effect. So instead of being more systemic and going all throughout the body, prostaglandins are more local hormones. And then our sex hormones, so again, these help support our growth and development of those secondary sex characteristics. So again, estrogen, testosterone. We have a few different inhalation agents. So again, oxygen, we don't necessarily think of as a drug because we breathe it to just stay alive. But it can be used as a drug, again, especially somebody that has pulmonary issues. But nitrous oxide that is used, so NO, helps with those cardiovascular issues, causes vasodilation. So these, again, are inhalations, so they're volatile liquids that easily vaporize, so that's why they have to be inhaled. So examples of the anesthesia delivered that we've mentioned in one of the first videos, so the desflurane and the halothane. So a lot of the general anesthesia is going to be by inhalation, but it also includes nasal sprays as well. Our irrigation solutions, so especially during surgery, we need to, flush out the area that's been opened up to remove the debris, to get the blood and things like that out of the way so that the surgeon can see. So primarily used for that debris, but sometimes they can be used prophylactically, so again, beforehand. They're not for injection, though, or for intravascular use. So again, these are large amounts of solutions that are being added. So some examples are non-electrolytic solutions. Some antiseptics fall under this category. Sterile water can be used, sterile saline as well. And then lactated Ringer solution is a common one that is used for irrigating as well. Right now, our IV fluids, so these are used to replace fluid, also electrolytes, so like Gatorade kind of thing. They can also be used to deliver nutrients or to directly administer medication to the blood, so just speeding up how quickly the drug's getting into the system. Now the three tonicities, and we mentioned a little bit about these before, like with the colloid plasma expanders and kind of the diuretics, but all solutions have three possible tonicities. Isotonic means that they're the same as the blood, so there's no fluid movement. So again, that's why saline is used. That mimics the inside of our cells, so water's not really moving a whole lot. A solution can be hypotonic, meaning it's less concentrated than the blood. So if a solution around the red blood cells is hypotonic, that's going to cause that fluid from inside of that solution to go into our cells. And then hypertonic has the opposite. It's more concentrated. So this was like the colloid plasma expanders, and that's going to draw fluid from the cells. So like the diuretics in those, that's going to increase the volume of the urine or the blood. But it's by creating this where we have a lot of solutes and it draws the water out. Some lubricants, so these are used just to help to decrease friction during rectal or vaginal exams, but they help also to facilitate insertion of like catheters, endoscopes, or other surgical instruments. Some are water soluble, meaning they dissolve well in water, and can contain like an antiseptic or anesthetic that would also be on them to help with the numbing or to prevent infection, whereas some are more petroleum-based, so like Vaseline-like. So these require some type of caution, though, because they are flammable. All right, now our narcotic antagonists. So again, antagonist means we're blocking something. Narcotics are those pain relievers that are addictive. So these are going to reverse the analgesic, hypotensive, respiratory, depressant, and sedative effects of those narcotics. So blocking all the effects of those. So some examples: naloxone, which is Narcan, flumazenol, and how these work. Again, they're antagonists. They're competitive antagonists, which means they bind to the same receptor site as what the natural opiates would inside of our cells, but they bind to those opioid receptors and they block them, so nothing else can bind. Again, they are competitive, meaning that the dosing definitely matters. So they're going to block the effect of those narcotics. Now, we also have our narcotic analgesics. So what is a narcotic? So the antagonists block these analgesics. So these are the opiates, which are the naturals, and then the opioids, which is anything that binds to an opioid receptor. So it includes the opiates, but also the synthetic ones as well. So these are going to reduce the perception and reaction to pain, so our numbing agents essentially. So we talked about like just analgesics in our first session, so like ibuprofen and those type of things that are pain relievers. Narcotic analgesics, though, are more addictive, more have a much greater effect. So this also increases pain tolerance for acute and chronic pain, and then most are in the OR that are used are Schedule II, meaning they're highly addictive, but they have a documented medical use. So lots of documentation. Of course, everything has to be documented, but these are more highly regulated because they are controlled substances. So fentanyl and hydromorphone are two main examples. Our neuroleptics and tranquilizers. So we have a couple different categories. Antipsychotic drugs fall here, so these treat psychoses and neuroses, but also nausea and vomiting, so it seems kind of unrelated, but it's how our brain works. So haloperidol is an example of one of those. And then we also have anxiolytics, so we think about like anxiety here. So it treats anxiety, stress, and irritability. So risperidone is example. We also have some OB agents that are used for those that are pregnant. So some would induce abortion to terminate the pregnancy. Some can stimulate or suppress lactation, thinking about breastfeeding. And then also we can stimulate or relax uterine contractions, so like oxytocin, that are going to contract, so that's used to induce labor. Also, it strengthens the contractions and helps to control hemorrhaging during delivery. And then there are others that are used to prevent hemolytic disease of the newborn. And so this is called RhoGAM, is the drug that helps with that. So Rho is an immunoglobulin that gets produced whenever we have an Rh negative mom that has an Rh positive baby, and especially if her this happens in the first pregnancy and she gets pregnant again. Now she has antibodies being made, and if the baby is Rh positive, it's going to attack that baby and that fetus, and it can cause death. So this RhoGAM can be used to essentially block those antibodies from attacking the Rh positive baby. We have some eye agents, so there's ophthalmic agents. So these are designed for use in the eye, often the same drug that could be used anywhere else. It's just specially designed and buffered a little bit different to be compatible with the eye. Manufactured in a special form that is safe to be used in the eye, and then its concentration is therefore adjusted to make it effective. So our sedatives and hypnotics, these are going to be both CNS depressants. So we talked about our stimulants already. These are going to turn off or turn down the CNS. So they're typically classified as narcotics as well. So we have narcotic analgesics, but we have some controlled substances here as well. So our sedatives are going to produce a state of calm. So if we're sedated, very calm, very relaxed. Hypnotics, though, are going to induce more of a sleep. So somebody undergoing hypnosis, there's some research out there that hypnosis can be good for treating some different types of addictions, as well as some other psychotropic illnesses. And these are going to include our barbiturates and benzodiazepines. This is mainly what they're doing. They're having this CNS depressant effect. Then we have some vagal blockers. So the vagal nerve is one of our cranial nerves. So these include H2 receptor blockers. So those antagonists. So again, histamine 2, we talked about these, but the gastric agents, because again, histamine, we usually think about allergic reaction, but H2, those increase secretions and gastric juices or acids in the stomach. So the vagal blockers, though, will block those as well. Also cholinergic blockers, so that blocks the parasympathetic nervous system, which is the same as kind of activating the sympathetic. Our vasodilators, we've kind of already mentioned whenever we talk about the heart agents, but put it in here again. These are going to relax the blood vessel walls to increase blood flow and lower blood pressure. Again, the coronary vasodilators just target the coronary arteries that go around the heart, or others would go systemically to all of the blood vessels. So some examples here, cyclodenolate and isoprene. And then our very last one are the vasoconstrictors. They have the opposite effect. They constrict the blood vessels in the wall to increase resistance and increase blood pressure. So ephedrine, metronidazole, and pitressin are 3 examples of those. So trying to increase blood pressure rather than decreasing it. And that finally brings us to the end of chapter 10 and all of the drugs mentioned here that are commonly used for surgery.